Hello, everyone. Just give us a couple of minutes more so that we allow some more participants to log in and then we can start. Hello and welcome everyone to our Volk webinar series. Today's webinar is on tips and tricks for clinical examination. And to speak about this subject, we are privileged to have Dr. Kenshuk Marwah, who is a senior ophthalmologist at Shivom Eye Care, New Delhi, India. Dr. Marwah has vast experience of over 17 years in the field of ophthalmology. He has completed his MS in ophthalmology from MNJ Institute, Ahmedabad, India, post which he went on to pursue his fellowship in Retina from Aditya Jyot Eye Hospital, Mumbai. Dr. Marwah was associated with Shankara Hospital, Ludhiana, and currently he is associated with Fortis Memorial Hospital, Max Pancheshil, and Bajaj Eye Care. Dr. Marwah has many national and international papers to his credit and has also presented scientific papers in various national and international conferences. In today's webinar, Dr. Marwah will share his experience on selecting the correct lens and some tips on how to use these lenses while performing clinical examination. With this, I would like to invite Dr. Marwah to take this session forward.
I would like to thank Meenal and the Volk team, Love, for giving me this opportunity to bring forth this very interesting and day-to-day usage with the lenses in our day-to-day clinical practice. So allow me to share my screen and I hope my screen is visible.
Yes, doctor.
And right. So moving forward for this today's webinar on the tips and the tricks of clinical examination. So I would be uh, using the three segments of the lenses, which is the indirect ophthalmoscope lenses, which are called the BIO lenses, and we'll touch upon the slit lamp based lenses, which are both for the retinal examination as well as the gonioscopy lenses. So the lens portfolio lenses, like I've already told, the BIO lenses, the slit lamp lenses, gonio lenses, and the new kid on the block, Vista View, for our clinical practice. And I'm going to talk more about it also in the later part of the webinar. So selecting the right lens design is one crucial question that comes along the residentship as well as in our day-to-day clinical practices, because we want to see more of the retina, of the optic nerve, and the viewing is everything. So first step in any clinical examination is observation. So the advantage with the Volk lens is it is not single aspheric, but it is a double aspheric lens with both sides tapering, and that gives a undistorted image, and that helps us to reach a better diagnosis and hence a better treatment. So a double aspheric lens increases the depth of focus and reduces distortion. So the lenses may have an optimum orientation for us to reach to a clinical diagnosis. And the other important thing is the anti-reflective coating that comes with the lenses. And I would here touch upon that the newer lenses, the digital lenses which have come, have give a much better and an HD view, I would say, with least amount of glare. So there is no glare at all. So anti-reflective coating helps to minimize the reflections and the glare layers. Coming to the first part of the webinar, the diagnostic lenses, the first lens that we hold as ophthalmologist and which is the most challenging part to learn during our residentship is the diagnostic BIO lenses. So here are some photos of me doing a BIO lens examination, and we have to, I would suggest, I would give a one very good tip to the beginners is anybody can start, using a BIO lens, and it now the indirect lenses are easily available. The indirect ophthalmoscope is easily available. I would suggest that the residents start from the temporal part, start looking from the temporal aspect, and then start to look at the other sides, asking the patient to look at various gazes. All these examinations are mentioned very nicely in all our textbooks. And the image is inverted and laterally inverted, which we have to make sure. So the image, my image is like it's upside down. So that is what you have to see, and you have to figure that in your mind that we have to make it straight. And how to hold the lens? On the lens there's a silver marking, and that silver marking on the lens edge should be towards the patient. So that helps us to give a better image. And the other thing is, if you cannot make out the silver lining, the letters which are mentioned, like in the above lens, aspheric, so that should be straight. Now coming and choosing the right lens for ourselves for clinical examination, what should we choose? So higher diopter means lower image magnification, lower working distance, and wider field of view. So higher the diopter, as you go to the higher diopter lenses, the image magnification reduces and the field of view increases. And as we go on to the other segment side, towards the more lower diopters, it gives us a higher image magnification and the field of view reduces. So, and like in the residentship, I started with a 20 diopter lens, and I still have that lens, and I use that in my day-to-day clinical practice. So 20 diopter like is used for the baseline, and most of us, old practitioners do have those lenses with us. So now coming to the image comparison. So I would suggest that we look forward for the around the 20 diopter lens and the 28 diopter lens that is used mostly in the pediatric cases, and it gives a much wider field. And because while examining a baby or a kid, we get a lesser time because sometimes kids get uncooperative and we have to look at the information quite quickly before the child begins to cry. So we need a wider field of view with a 28 diopter lens. So you can see as the magnification is increasing, the field of view decreases. Now coming to the bio lenses, now currently 20 diopter lens and the pan retina 2.2. So most of the residents have this question that, what is the difference? Because we use both of them in our OPDs. So in the 20 diopter lens, the field of view is 60 degrees, whereas in pan retinal 2.2, it's around 73 degrees. So the field of view is much better in pan retinal 2.2. So, my choice, personal choice is now pan retinal 2.2, and it gives a roughly same amount of image magnification. So your field of view actually increases. So while you're looking at the periphery, you don't miss much things. So these are the few images which I have taken. The above images are through the pan-retinal 2.2, and this is the patient of papilledema, where you can see the disc is edematous and the hemorrhages, splinter hemorrhages, which are there. And the lower image on the left-hand side is of the Ozurdex implant in the eye, which we had given for a non-infectious uveitic cystoid macular edema. So you can see the Ozurdex implant floating in the eye. And the other image, what we regularly face and we have a battle to fight with as ophthalmologists, and it is our duty to examine the diabetic retinopathy patients. So the other image, I made a collage with the, these are images are actually taken through a Volk 20 Volk DCM lens, which is the which gives a higher magnification. These images were collated by using the Volk DCM lens, and it shows a proliferated diabetic retinopathy. And this patient was later lasered, and his vision was saved. These are another image, like I say, the India is the capital, diabetic capital of the world, and these are the patient with a fresh bleeding in the eye. So these patients don't control their sugar and the HbA1cs are high, but they come and they become, more aware once they have such high risk PDR in their eyes. So when a patient starts to have bleeding and then we show these images, patient gets more aware and he takes more care of their eyes. So these images have been taken recently, just 2 days back, by pan-retinal 2.2 lens. So, and the other thing which I advise the students and the residents and fellows to do is practice the scleral indentation. The scleral indentation is helps us to have a better look of the periphery, and it's a very easy art to do. You just have to be very gentle with your hand, and maybe with a Johnson bud, you can do an indentation. The image on the left hand side shows the two lattices with holes. You can clearly see that the image is taken so beautifully with the lens. And the middle image, which actually shows a retinal hole with lattice. And if you are, good enough and your hand is stable, you can even take pictures up to the pars plana. So the last image which I'm showing, left hand side shows the retina. The middle line is the ora serrata, and further than that is the pars plana. Pars plana is the part through which we make the vitrectomy ports, as well as give intravitreal injections, intravitreal implants. And this is the place where we are putting the implants these days, and even extended release implants are also put through the pars plana. So the images actually speak for themselves. So, we usually talk about what is the image and what is the magnification. When we actually do clinically, then we get to learn and get a more experience what a indirect BIO can actually do. So it all comes with practice. So just, even after finishing OPT, one must spend time, and it is all about maneuvering your hand and tilting the lens. I will talk more about that. So this is another patient. This is an image actually taken from a pan-retinal 2.2, and the left image shows a horseshoe tear. I have marked for the residents this blue line, which is on the shape of the horseshoe. So this patient needs an urgent laser, and the right hand image, the extreme right hand image, is showing how I'm doing the laser. I have rested my fingers on the patient's chin, and with the index and the thumb, I am manipulating the lens to give the right laser to the patient to put a 4 or 5 rows of barrage around this horseshoe tear, and the patient is happy. Now, like I told about the digital lenses, so digital lenses actually have a much better coating, and these are the new lenses, and you can see the grip for the lenses is much more easier. Because with the older lenses, with the usage they tend to sometimes slip. So, but with this has a better grip, and digital clear field lens is almost like a next generation 20 diopter lens. And I don't know the exact costing, but the costing is not too much of a difference between the lens and the 20 diopter lens. So you actually, I would prefer that we start with a much better lens with our when we are training, so that we can see better. And because initially we get with the glares and the focusing, we get disheartened, and we leave that thing in between, that I cannot do the indentation and I cannot see the retina. It is just about being patient and using the lenses. So digital clear field lens is almost as equal to pan-retinal 2.2. It gives a high resolution image. It reduces the chromatic aberrations, and definitely produces a high resolution image. It's like an HD. You're looking through an HD lens. So and it has an advanced AR coating. I have both these lenses with me, and digital clear mag lenses I used to see for my glaucoma patients, because the optic nerve is seen very clearly. Sometimes, when you are wearing an indirect ophthalmoscope, you just want to see through a digital clear mag, and it gives a very good resolution of the central part when you're looking at a diabetic patient. you want to see the central macula also. It gives a very good view of the central retina. Now coming to the pediatric essentials, I have been doing retinopathy of prematurity screening. I've been, seeing babies in corporate hospitals, and I would like to share some images which I have taken. The extreme left image I've taken with the 2.2. It is the lasered ROP. ROP examination is actually a sight saver for the kids, and the second one, the golden lens that you're seeing, is the 28 diopter lens. I am showing the baby was examined, and his blood vessels moved on to the zone 3, and the baby, the ROP examination was completed. The parents were really happy. The second baby had anemia at birth, and a lot of blood transfusions were given, and it shows hemorrhages in the central part. And this baby was also examined, and the resolution took place. And the top image with the red lens actually shows the cherry red spot. During my practice, we actually hear a lot about some of the diagnostic signs, but actually we see them very rarely in clinical practice. So that was such case that this baby was actually referred to us by a pediatric neurologist, and we told them and discussed with the pediatrician, the pediatric neurologist, that it looks like a metabolic storage diseases, and the patient had actually traveled world over, and no diagnosis was being made for the patient. So the lenses and our the image actually helped us capture the diagnosis, and the baby was put on the right treatment. The baby was diagnosed to have a metabolic storage disorder called the Tay-Sachs disease. So these are my happy babies, and this is my routine practice. It's an engraved, specialized, personalized lens which I'm using for my ROP examination babies. 28 diopter lens is what I use. 30 diopter lens can also be used, but I would suggest that during our residency, when we get time to go visit the wards, and it starts in the second year. In our M&J institute, we used to do it in the second year. So I think one should start evaluating babies through this lens is very good for the practice. So one can take a screenshot of the field of view, the lens, and how much is the magnification, and even the laser spot magnifications have been mentioned, and what is the ring size. So in the FO view, the field of view, when you read this table, so it shows 36 degree like in macula plus. So that means when you hold the lens centrally, the image is 36 degree. But once we ask the patient to look up temporally or nasally, the field of view actually increases. So in the 20 diopter lens, the central field of view that we get is around 46 degrees. But once we, examine sitting centrally, we can go up to 60 degrees view also. So this is about this table. Now, moving on to the next segment of our talk is the diagnostic lenses, the slit lamp lenses that we use. Most of the ophthalmologists are using the slit lamp lenses. I started my residency with the 90 diopter lens. The 90 diopter lens is very commonly used. It's easy to carry. Same with 70 diopter lens. So somebody is already acquainted with the 90 diopter lens, which gives the image magnification of 0.76. The image magnification is a good part in the 78 diopter lens. So the 78 diopter lens gives a very good view of the optic nerve, of the central macula, and this is also very essential. So I use both the lenses while I'm actually having a look at the patient. So talking about the next generation lenses, I will talk about the super 66 degree. So super, you just if the the number is almost the same, like 66, 78, they are almost the same. So if you even you try super 66 or 70 degree, they give a good image magnification of the optic nerve. And then there are other lenses with the super field lens. As the name suggests, it is gives a much higher field, and it is almost like a super 90D. So, and the other lenses are the small pupil lens, and I have just recently used a small pupil. We can actually see through 1 mm pupil size also, and the working distance in this case is 4 mm, and the field of view is almost like 103 degrees. So with the super pupil is actually used by most of the glaucoma specialists, because sometimes you are putting them on pilocarpine and you want to see how the optic nerve is behaving. So this can be actually very easily seen through a very small pupil, and the images, you don't have to try hard. That you can just focus the lens and you can see the optic nerve very clearly. Now coming to the digital lenses in this segment also. So digital lenses, like I previously told, also they have a much higher anti-reflective coating, so it gives a much high resolution image. So digital high mag is the third generation 66 degree diopter lens. So this also gives a very beautiful view. Even you can see the ILM folds on the macula. So this gives such a good magnification. As well as digital one is the for examining the cup to disc ratio and provides a very good stereopsis. Digital wide field, sometimes I would suggest that some ophthalmologists are not comfortable with using BIO. So some people are not trained in doing the indirect examination, and this is a repeated question I get from the senior ophthalmologist, my colleagues, that I don't do an indirect. What should I do? So I recommend to them that they actually take a digital wide field that gives a much better field of view, which is approximately 103 to 124 degrees. So that actually helps. And nowadays people are doing the ICL surgeries, the LASIK surgeries. In all of these cases, it's mandatory to check the periphery of the retina. So how to do that, before actually referring, even that you can, diagnose it, and you can, call your retina specialist friend to actually do the laser for you. But, the diagnosis also becomes, you also become more confident while you are using a digital wide field. So these are the various image comparison. You can see the 60 diopter and the 78 diopter lenses give a much better view of the optic nerve of the macula, and 90 diopter gives a much wider field of view. So, like coming again to the clinical part of it, I want to show more of the clinical scenario so that we take home messages that what we are actually seeing clinically, that is what matters to us. So this is a very beautiful case that came to me. Was had a retinal detachment in the other eye. A patient had a coloboma. This was his left eye, and because the image is inverted, this is the inferior coloboma actually. And you can see through the 78 diopter lens, you can see the optic nerve very clearly, and only the superior aspect of the coloboma. Whereas through a 90 diopter lens, you see the field of view increases, and you are able to see almost up to the inferior edge of the coloboma. And we lasered that patient, and you see the same patient through a digital wide field. Those small white dots around that yellow part is basically the whole up till the aura. So that is what we can see through a digital wide field lens. So you can see the inferior aspects of the laser marks that have been done on this patient. So this is the the clinical aspect of what we are doing with the lenses, what we are observing. And on the follow up, anybody, if I'm not there as a retina specialist, my colleague, if my wife is also seeing a patient, they can see the patient that has been lasered very nicely on a slit lamp. So these images are taken on a slit lamp, and it gives a very good view of actually how the magnification is, what you are actually looking at. So this is a very good example. And now coming to the 90 diopter lens, the right image, you see the black eye, and it is a post trauma. The patient had a fight with somebody, and you can see the choroidal rupture lines from the 90 diopter lens just concentric to the optic nerve. So those are the choroidal rupture lines which are seen and photographed on a slit lamp. And I tell you, it's not easy to take images on the slit lamp on these lenses. So it takes around 10-15 minutes to actually acquire these images. So coming on, this is a new innovation by Volk. It came around the COVID time. So people were having a lot of difficulty while uh, they were examining patients. There was a lot of fog on the lenses, and the view was obstructed. So it was, uneasy for the patient to sit so long, as well as for the doctor. So this ClearPod actually helped to lift the fog. That but now also a lot of flu is coming up. And patients are coming with masks. So and these ClearPods are made specific for each kind of lens. So for 90 diopter lens, there's a specific ClearPod that comes. So it's a perfect fit with your lens, and the cost is very economical. It is, you can take it with this, and it actually provides the right working distance for each kind of a lens. So I'm just going to show you in the other slide. This is a patient where I'm using this clear pod lens, and you can see the marks. There's embossing on the clear pod, which for which lens it is. It's a 78 diopter lens or a digital wide field lens. Which lens we are using it for? So this is exactly, it fits the perfect lens, and it actually provides the right working distance for the residents, for the fellows, for the clinicians, that you don't have to maneuver your hand. You are just at the right distance from the cornea so as to view the optic nerve and the macula perfectly well. So this actually provides the right working distance, which is according to the lens. So this is a just an overview of the magnification versus the field of view, like the general dictum which I have been discussing with the BIO lenses. As the magnification increases, like in the digital high mag, the field of view would decrease because you are compromising on the field of view. In lieu of that, you are getting a magnification. And as such, you move forward like with the super pupil XL, which is at the end of the spectrum, you get to see through the small pupil also, as well as get a wider field of view. So, for most of the glaucoma specialists are using super pupil, and it is very easy to use. So now coming on to the next lenses, which are the gonio lenses. So gonio lenses, the things to consider is that what are the types of gonio lenses? This is the one thing that, we as fellows, as consultants, as clinical practitioners, which material to take. The lens materials usually are glass or acrylic. So glass series comes with the G series written on it, and the acrylic lenses are usually the 3 mirror and the 4 mirror lenses. And usually there are coatings, which is the anti-reflective coating. Sometimes they're uncoated, and the contact elements are with flange, without a flange, or advanced no fluid. So it's the no flange lenses only which can actually be used for the indentation. So, I suggest, the first lenses that we buy should be the no flange lenses, because they help us to indent. And sometimes there's a handle also is there, depending on the ring size, the small ring or the large ring, and the number of mirrors on the lenses, it's denoted through that. So people ask that should we go for a 1 mirror, 2 mirror? So the number of lenses also, the mirrors actually define the lens. So like here, the image on the left hand side shows a flanged contact lens. It has a small bulge or a flange, and it requires a coupling medium, like an HPMC, which is used. And so you just fill in the HPMC, put a paracaine, and put the lens in. With the no flange contact, you don't require any fluid, and these are more faster to do and less cumbersome to do, and they also help us in the indentation. So the 4 mirror and the 6 mirror are useful for indentation. Most of the residents ask me which lenses we should actually go for. I would suggest that 4 mirror, so it actually helps us for indentation, as helps us to make our work faster. And then there are the ANF lenses, which also don't require any fluid, but they cannot be used for indentation. So these are the images of the 3 mirror with flange, and the G4 4 mirror with the flange. These are the images taken by me of the 4 mirror lenses. So the image here, just defines us. So it's much more easier. Our work becomes more easier, that we can see the superior aspect of the angle, the inferior aspect of the angle, and the temporal part, nasal part all together. So we have a quick look at it. But for my colleagues and my residents who have just started with gonioscopy, I would suggest, at the end of your OPD, get hold of one patient, get hold of a voluntary patient, and we are thankful to our patient who have been patient with us for helping us to master the arts of gonioscopy. So you need to put a lens on every day, so that you get to practice your lenses, and you see how the various markings are, and helps you become a better clinician. So gonio lenses, the next generation gonio lenses, the G4 and G4 high mag, which are the all glass design for a magnified anterior chamber imaging, which gives a 1.5 times image. So G4 has a more image magnification than the G4 gonio. and ring size are variable, large, small, or two position. And in the G6 Gonio, it's a all glass design for a six mirror. And I'll just show an image of how a glass six mirror looks like. So this is a actual patients of my images. We showing the six mirror, and the six mirror you are more confident, but I am more happy with the four mirror. It's a personal bias. And commonly encountered issues while doing the the like examination on the slit lamp is with the small pupil. So with the small pupil, like the 90 diopter lenses, they actually help us see through a small pupil. So that is why once we start with the 90 diopter lens, you can actually see through a small pupil. You just need to with your hand, you just need to maneuver your hand a little bit so that to focus it. While you're holding the lens, you need to just work at your wrist so that you can just change the angle and have a clear look at the optic nerve. So that is what we need to maneuver while using our lenses for the small pupil. And how to avoid the glare. The lens should be slightly reduce the reflections. Is you slightly reduce the light luminosity and see through a light dim illumination, because that actually helps to increase the pupil size. So in my clinic, what I do is I switch off the light also sometimes when I have to concentrate on the disc. So I ask maybe a small dim illumination is on, and I focus on the optic nerve. So to reduce the glare, one thing is to reduce the illumination as well as also switching off the light that will expand the pupil. So these are the clinical things which we have picked up over the years, that how we should be doing this commonly encountered issues, how to tackle those. So and the other thing is what the lenses which I bought in the residency, our professor Dr. Shashank Patel was there, so he was very particular on how we should be taking care of our lenses, the bio lenses, and so he always says that rinse your lenses with warm water and gentle dish soap, whatever the soap is available, and it should be always cleaned in a clockwise direction. So and it should be with a lint free cloth so as to keep your lenses clean. Because sometimes dirt also comes up on the lenses, so always keep your lenses in a place where there's less of a dust. So keep it in a box. So obviously a box comes with it, but keep it another box so that dust doesn't come up. And the other issue is high magnification. Any lens movements are exaggerated at high magnification. The key is to practice, with the technique down, and can make the transition easily. So learn with the basic lenses, and then you can slowly turn up the magnification and see. And the other thing is sometimes you are holding the lens upside down. The silver marking in the case of BIO lenses should be towards the patient, and sometimes the patient is blinking. So, for that, you reduce the magnification. So, always I ask my colleagues to, sit on the other side and see how much the bright light of the slit lamp is. So, always keep that brightness low so that your patients are comfortable. Everything that we are doing is for a better patient interface. So, patient is comfortable and we are also comfortable. Now, see, like this is a dirty sky lens, and the amount of glare that we are seeing on the left side, and with a good clean lens on the right side, the image of the retina is also much better. So, if you keep your lenses properly, you buy a different platform of lenses rather than, keep one lens proper. So it's a compounded benefit. So, it's like a compound interest. So you add one lens and then you add another lens, so you keep on slowly adding lenses in your clinical practice. If you keep your lenses which you already have properly, so it will be good for a clinician themselves also. So clean lens is essential for a crisp and a detailed image. So, like I told that we should use a lint-free cloth, and I have used the Volk Precision Optical Lens Cleaner, this white pouch which is there on the right side. If you happen to visit any stores in any of the conferences, Volk is there and the official distributor is there. I would suggest that use these cloth which is provided by them, the optical lens cleaner. It actually works wonderfully, and your lenses will be clean, crisp, clear, and I have used it, and I've used the Vogue lens pen also. But this is a must-have. Like when I do my retinopathy of prematurity screenings, and I need that clarity for examination, for doing a laser for my patient. So I want my lenses absolutely clean. So this uh, POLC, which is called precision optical lens cleaner, is the best. So maybe it's sort of biased, but it actually works, you know. So the rinsing and everything I've already told that it should be used at a room temperature, and a sterile distilled water, and no tap water should be used, or a deionized water should be used for cleaning. And the other thing is that during the winters when we are doing the retinopathy of prematurity screening, the lens tends to fog up. So like in the previous slide, which I told that you can use this with the soapy water, and you can clean it, so that actually helps to prevent the fogging aspect, which is also very cumbersome during the examination. So that is a problem which is encountered in winters. I don't know if other people, consultants also face that issue. So this is the lint-free cloth, the Volk cloth which is available. Never use a microfiber cloth, or sometimes gauze pieces are available in the vicinity where we are seeing the patient, and we use a gauze piece. Those are not to be used because they cause scratches on the lens. So we should avoid the lint cloth or these gauze pieces to clean our lenses, because these are the primary culprits causing the scratches on our lenses. So now coming to the new kid on the block, and something which I've used in my clinical practice, and have used Vista View. So basically, it has a mobile interface which is provided by the Volk, and it's so easy to use. The patient interface is very easy, and you see me clicking on that, and the image on the right hand side, you can see a voice activation. It is there on the slide, and the voice activation, you just have to use those magic words capture, and it actually captures the image of the retina, and it easy to use. The images are easily transferable via Bluetooth and via email and others, so it is very good for telemedicine also. And you can see it actually fits very nicely onto that slit lamp, and it can fit onto any slit lamp, so it's easy to use. So it's an intuitive design. It gives a wide free 55-degree field of view, and like I said, voice activated capture I have also used. And as you say, capture, it takes 1 second. It captures the images, and there's an autofocus, adjustable illumination, which is there. And the patient workflow, like I said, like it's very good for telemedicine, and you can take images and it can be wirelessly transferred to a computer or your EMR system what you're using in your clinical practice. And it's very easy. Your technician, your optometrist can take images via that. Some people who are doing corporate testing, and in villages, in camps, if they have a tertiary center, for them also, through your trained staff, you can get the images to your retina specialist to see. I think this is where the world is coming up to, that our workforce is not growing in that regard, but at least with the technology like this, the images can be transferred to a tertiary care center, and the diagnosis can be done. So the things are very easy. The patient entry is good. The image capture is also very nice. Review and analysis can be done. Even patient education can be done. In today's time, seeing is believing. And like I said, again, India is the diabetic capital of the world. This is the biggest fight against blindness that all ophthalmologists are doing these days. And patients need to be aware, because patients don't know the severity of the problem. And once they see, the images like this with blood on the fundus, at this case is a moderate diabetic retinopathy. But if you tell them, the patients, to be cautious at this time, as you can show the colored fundus, even the red-free photos can be done. So, one could not imagine while we were doing a residency that, gadgets like this will come, through which, maybe FFA will also come, maybe in some of the Vista View in the future. So this is just the beginning of telemedicine. So, and so many AI platforms are also coming in, where you don't even need a person to be there as a doctor interface, where the AI actually, does the diagnosis, and then the images can go to a doctor. So these things are coming up in a big way, and these images from the Vista View are clear cut. I like the other images which I showed. We have taken images of the laser done in patients of proliferative diabetic retinopathy. Maybe in some other seminar, I will also share, the images done post laser, and we have taken images while Vista view. So these are, the telemedicine things we have done earlier, and I've been a part of such activities, the corporate activity. We had a diabetic awareness camp in which we did without dilatation through one of the other products of Volk. And during the diabetic awareness, we had spread this message of, diabetic screening in the community as well as screening for glaucoma. So for optic nerve evaluation. So we did at three centers, two in Delhi and one in Gurgaon, in association with Fortis Gurgaon. We had done awareness, a diabetic awareness during the diabetic awareness week, and it was widely accepted. And coming to the work customization, now we have custom engraving. So I just want to share a very interesting thing during my residency. Only those black lenses were there, so we used to always mix up the lenses, and so we would miss those lenses. But with the color specific coding, now you have all those beautiful colors. So you can have different array of colors in your practice: purple, red, yellow, green. So these are the various. And now the custom cases have also come in where you can keep all your lenses, the gonioscopy lenses, the Slitlamp lens as a 20 diopter lens, all in one place. So these boxes also come in various colors. So my only take home message is that, never compromise in, buying those Chinese lenses. You would feel the cost is, very attractive, that they are cheaper. But, with actually coming into the clinical domain, and you're not able to make a right diagnosis, that would not go a long way. So I would suggest that, our colleagues are, we should actually go in for a get a good diagnostic lens, either it's a slit lamp lens or a gonioscopic lens, because those lenses, I had been 17 years. The first lens which I bought was 17 years back. So I bought a 90 diopter lens and a 20 diopter lens. Now I have, two clinics come up, and I'm using, those lenses very frequently, on almost every patient. And, it goes a long way. So my take home message is go in for a good lens. Even if you're like people actually wait for the conferences, I would request the work team to, maybe give a special discount, or people who have attended this talk, and for residents that, they get in the lenses through the work distributor themselves, and, they start with a good diagnostic lens. And with that, I, if there are any questions, we can take that up. And thank you for the patient listening.
Yeah. Thank you, Dr. Marwah. Thanks for sharing those valuable insights and sharing your experience of how you have been actually using the lenses and selecting the right lens for your practice. There are some questions that are there from the participants. The first question is like a 20D, can we use 78D for performing laser procedures?
See, for the laser procedures, we actually require something which has a contact medium, and those laser lenses are separate, and the laser lenses come separately because you need to have a direct touch with the cornea. So I don't suggest 78 diopter lens, but there are other portfolio lenses. You can actually go on to the Volk.com site, and you can actually the list of the lenses is mentioned there. So I just happened to just, while I was making this, I just happened to be on the site, and you can find the lenses specifically for the pan-retinal photocoagulation as well as the focal and the grid laser photocoagulation. So those lenses are separate.
Yeah, thanks, doctor. I think, doctor, you have touched upon the cleaning part of it, but there is still a question is how to avoid getting scratches on the lens and increase its lifetime.
So, like I visit a lot of clinics, and, when I don't see a lens kept properly, it really irks me. and it irritates my nerves. So I'm a very patient guy, but sometimes what we unknowingly do is we keep the lenses on the table, or it should always be kept in a case, and you should never touch the lens surface, because if you touch the lens surface you leave the thumb imprint. And in our practice, the first thing, like Dr. Shashank Patel, like he was our professor, he used to tell us always give a lens also, and it should be holded lens to lens rim, not on the lens surface. So sometimes you have an assistant in your clinic and he's giving you the lens from the case and it touches the lenses. So that is the first mistake that has already been done. The second mistake, we unknowingly put it on the table and we put a scratch on it. So these small things go a long way. So keeping a eye on the minute things gives us a better picture. Same is with the lenses, that we have to be patient with our lenses and we have to take care of them like something valuable.
Yeah. And how to clean the lens?
So like I have already shown in my slides, and that for cleaning the lens, you should have a maybe a distilled water or a non-ionic water that is suggested, and maybe a soapy water. So you make a froth and then maybe clean it with a lint-free cloth. And I would suggest that special work tissues that come, which are the white pouches. I think if you have an access for that, or a Volk lens pen, they are the best, because with the once you have to do it in the clockwise fashion, and the other thing is, like with the pen, it has a small micro bristles also, so that actually helps us to remove the dust from the edges of the rim where the lenses are attached. And it should be done in a clockwise manner, because if you do it in an anti-clockwise manner, the lens might come off the rim. So that is what we have to take care, that we do it in a clockwise manner. That's the reasoning behind cleaning the lens in a clockwise manner. Because in the anti-clockwise manner, you will open it like most of the machinery of the corks and the screws which are there. So it's a basic science dictum that you have to put it in a clean it in a clockwise manner, so you don't loosen the lens up.
Yeah, thanks for that answer, doctor. The next question is, can you share your experience between a Vogue Pan Retina 2.2 versus a optical 22 diopter max field lens?
See, that is what, like if you're talking about the pan retinal 2.2, and see it because you are doing through a BIO lens and a pan retinal lens. So these are two different things. But I would, at the end of the day, because I'm a retina specialist, I would do my indentation and do a 360 double check. So my personal preference is that. But if you are comfortable, you're not comfortable with the BIO, then you go for a pan retinal lens or a super wide field lens. So that would be good, but it all requires a little practice.
Okay. Doctor, the other question is, what could be an ideal initial set of diagnostic lenses in each segment that you suggest?
Yeah. So, like, coming to the slides and overall overview, I would suggest that the first lens. These are my personal choices. So, if you are in a clinical practice now, everybody has those diagnostic lens. You try it for yourself. My first take would be that. Secondly, my personal favorite is a pan retinal 2.2 for a wider field. So, for the BIO, I would prefer a 2.2, and for the slit lamp, I would start with a 90D, but maybe, like, if going back, I would have got the 70 diopter lens in my second year of residency, because that 90 diopter gives a much wider field of view, and this lens, the digital wide field, or a 66 diopter or 78 diopter, you choose whatever you want to choose. You see how those lenses are, how they work, and the first preference would be in the slit lamp 90D, and in the this thing for the gonioscopy, go in for a four mirror non-flange lens. Going for a non-flange lens is because you will not remain at the same stage. Some people want to start with a one mirror or two mirror. I say buy a four mirror, because with the non-flange you can do an indentation also, because you sometimes need to indent and see that the angle is actually what is the grade of the angle. So I would prefer that we actually go in for the four mirror in the gonioscopy section. Rest, like I said, it's a compound interest. You keep on adding lenses. So first year, maybe you buy those. And the second year, maybe, if you're doing a pediatric retina examination, you buy a 28 adapter. And, for a slit lamp, maybe you go in for a 78 adapter. So buy that in the second year. So, I would suggest that, we start with these three lenses first. And then maybe, as and when you mature with your clinical understanding and clinical practice, then you move on to more lenses. And I would suggest that during conferences also, wherever the Volk stall is, go there. There are the dummy eyes and the slit lamps are also available in some of the conferences, like the All India conferences, where you can actually see on the slit lamp and on the dummy eyes what is the field of the view and what is your comfort. So I think that can also be done. And the other thing is you share your experience with your seniors and your professors and do what they guide them, what they guide you, because that has been really helpful. Looking back, it was our professors who taught us all these things which I'm saying through the webinar. It is their teaching, and I am passing on to the listeners. It is through experience and through colleagues and through mutual discussions that what is our experience and how that can be utilized for clinical practice.
Yeah, thanks for that, doctor. The next question is, what is the magnification power on the slit lamp while using the slit lamp?
So like I prefer, like I told, that the magnification should be bare minimum, because as you go on to a higher magnification, like I said, there's a lot of glare and the image moves. So don't jump onto a higher magnification first. Keep it a lower magnification, lower illumination, and maneuver your hands, your wrist while you are doing it. Keep these three fingers, this on the headrest, and then move your hand. So that actually helps us to maneuver it while doing a slit lamp examination on a 90D or say a 78 diopter lens. So that helps. So I would suggest lower magnification rather than going on for a higher magnification.
Okay, so I think the next question is pretty much in line with this again. Now, this doctor has been using a 90D for last 3 to 4 years. So the doctor would like to understand is what will the doctor achieve if they start using a 78D now?
So what he will achieve is, because it makes a clinical, your analysis much better, because like in the slide we have also mentioned, as you get more magnification, the field of view, the magnification decreases. So you're not actually looking at more of the thing which you want to look at. See, if you are a look at the optic now, if you want to look at the macular edema, the first impression actually comes while you are looking at the patient clinically. The OCTs and the FFAs come later. So the first interaction with your patient is a clinical interaction, and when you are looking through a 78 diopter lens at that optic nerve, you will see a difference in the clinical practice. You have to do it to believe it. It is something like that. So I use a digital mag lens, so which is like a 66 diopter lenses. So I compared both of them. So the digital lenses actually give you a less glare. So you have to look at that. What you are observing at. It's like looking at the stars through a telescope. Why you go in for a higher grade telescope once you're moving more into your astronomy? Because you want to look at more galaxies and more things clearly. So this is that. So you have to have that passion, and you have to understand what you are actually looking for. So the whole picture changes.
Um, there are some couple of more questions, doctor. I hope you're comfortable with that.
Yes, 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 please.
Yeah. So what is an ideal way to learn the correct working distance while performing slit lamp examination?
So the ideal working distance, like this is a new innovation which I talked about, is a Clairford lens. So clear lens also provides the ideal distance which we are from the patient's eye, so as to look at the retina or the optic nerve more clearly. So that provides the ideal distance which has already been checked. So using a clear lens actually makes your work much more easier. And the other thing is to maneuvering. So you need to be your hand needs to be stable. So because you're the right hand, you are actually maneuvering the joystick of the slit lamp. Here you're trying to focus, and with the left hand you have to keep it stable. So there's a lot of eye coordination and the hand coordination comes into the play because you are doing a soft maneuvering. So one hand has to be stable on the slit lamp. The other hand is actually adjusting through the slit lamp. So that is why you need to. That's how you stable and that's how you work out the correct working distance. Today also, we I've been using a ClearPod lens also. The ClearPod helps me make it easier. But when I was not using ClearPod, I had to maneuver till I get the right focus. So that ClearPod saves the time, as well as patients who are coming with a mask. Because most of the elderly patients who come to Gurgaon and my clinics, they are wearing a mask, and the fogging that happens, it takes care. It actually serves a double purpose.
The next question over here is, I'm not comfortable with IDO examination. Can you please share your experience in performing these procedures?
Yeah. So, like in one of the slides, I said, like while you are doing a indirect ophthalmoscope, first thing is the each eye you close separately. See, the difference in the BIO is binocular. Binocular, the name itself suggests that you are using both the eyes. So first, when you put a binocular on your head, you should see that first it is comfortable. You are able to close one eye and the other eye and see that you are able to see through both the eyepieces. Once you are okay with that, then you take the hand and try and look at the temporal thing. First, just practice looking at the temporal retina. Just practice that part only. Don't, start with charting the whole 360-degree. Nobody started with that. I actually started learning indirect ophthalmoscopy while I was a senior resident at, Gangaram Hospital where I was doing internship. Then I used to see. I could not see because one is your proper indirect ophthalmoscope. The second thing is holding the lens at the right thing, and the other thing is holding the three fingers on the patient's head. You need to rest it so that you can adjust with your index and the thumb, so you can adjust your working distance. So as you move closer, so one of my colleagues actually gave me this idea that you more you go closer to the patient's eye while you are doing an eye, so that gives you a magnification also. So it is not just the lens magnification, it is your movability while you are holding that lens. When you are moving closer, you get a wider picture. So, it comes with time. Start with the temporal aspect because that's where you can see the aura. You will get more confident, and then you start to, see at the nasal side. First, see the temporal side, then see the nasal side, then go for inferior and the superior aspect. Start practicing with the temporal aspect of the retina. Screen those patients who have come for cataract, who are, in now also in most of the government colleges, the patients are kept overnight, till the time they are being followed up for cataract. Dilate the other eye, see those retina cases, see them on the slit lamp. You know, that is the time when you spend with the patient. That is a time of self learning. So self learning, I would say, is a kind of meditation. You have to do it. You have to do it for yourself. So learn on a patient and take time. So start with the temporal and then with the nasal, and then slowly you would gain more confidence.
And just in continuation with the same question, doctor, as a beginner, which lens would you suggest to start a wide field examination in case of an IDO?
In case of an IDO. So
Yeah.
in case of an IDO, I would suggest either a 2.2 for a beginner, 2.2, because
Okay.
2.2 gives a wider field and not compromising on the magnification. So that is what I am trying to re-emphasize again and again. If this is your first lens, I would suggest go for a 2.2. Eyes closed, go in for a 2.2. not a 20 diopter, go in for a 2.2. That would give you a much better view of the aura, give you much more confidence, and then later also it will help you in your clinical practice. Whether you are an anterior segment surgeon, whether you are a posterior segment guy, anterior segment people also need to have a confidence of seeing the periphery. It will help you. Now the things are becoming much more affordable with the Indian market also. So I think start practicing with a BIO during your residency or on your patient. So you will, if there any doubt, you are you can reach out to me through the work team. Email is also mentioned. If you have any doubts, you can always discuss.
Doctor, one last question. Can VistaView be used as a screening device? And what has been your experience with this device?
So definitely VistaView is one thing, it's very lightweight. It is something which is not very expensive, and it comes with a software which is designed by Volk. It has been, they have a repeated testing of these gadgets, and they make sure that the images are of an optimal quality. And the patient entry is very easy. That for a diagnostic device, I've already shared the images of a diabetic retinopathy patient. So if you are using those devices and seeing for yourself that I have also taken photos of patient which we have done laser. Those have also come very nicely. The patient whom I showed who had a high risk diabetic retinopathy, and those images were just done in 1 second. It hardly took less than 10 seconds. So the image quality is good, and the software is good. So that way, as an imaging device, as a primary, it can be put on a slit lamp. So I had previously used in a like a diabetic retinopathy camping. We had checked it, but this is the first time I checked it on the slit lamp. And these images which I have taken, it took about 10 images, and they all came out nicely. I was totally happy with the quality of the image. And so that is what we look in a device which has to be used in telemedicine. Easy to use, patient registration easy, data transferability should be easy. So all these criteria are met, and it is very lightweight. It comes in like small lunch box, or a small box which is lightweight. You wouldn't feel that there's a device in the bag. You have to open it to just recheck it that the device is still there. So the lightweightness is amazing. You have to. I think you should definitely visit the stall in any of the conferences and definitely see it for yourself. That it is how easy to use, and for your clinical practice and for your camps and other things. It is something to definitely have.
Yeah. So, thank you, doctor. Thank you for such a wonderful session today. Thank you for your time, and thank you for sharing all the experiences more from a practical standpoint. And we also would like to take this opportunity to thank all the participants. And as doctor suggested, if you'd like to have a look at our VistaView or any of the products, please go onto our website, and wherever you are in which part of the globe you are, you can put in a request asking for a demonstration or for an experience of our products. And we have our distributors almost globally in most of the countries. So somebody will definitely get in touch with you to show you the products from there. So thank you, and we look forward to seeing you all again for our next webinar. Thank you.
Thank you so much.
And thanks, Dr. Marwah, for everything. Thank you.
Thank you, Meenal. Thank you, Love.